I invite the last speaker in this second session, Professor Antoine Schneider from Switzerland. He is medical doctor at Adult University Intensive Care Medicine, Lausanne University Hospital. He graduated from the University of Geneva and trained as an internal medicine intensive care specialist at University Hospital of Lausanne and completed PhD at Monash University, Melbourne, Australia. We will talk about a very important topic today, which is very important in our clinical practice, drug pharmacokinetics and the drug removal with adsorption. Please, Professor Schneider.
Thank you very much for the introduction, and I want to echo the previous speakers with thanking Jaffron for organizing this very successful meeting and for the invitation. It's a very great time here in Zhuhai. So we've discussed lots of topics, cardiac surgery, we've discussed burn patient, rhabdomyolysis. In many of these patients, we're going to administer drugs, and we're talking about doing a procedure, hemoadsorption, that is removing the bad stuff, but we want to make sure we're also not removing the good stuff. And by that, I mean, of course, mostly antibiotics in these situations. Oh, yeah, sorry. That's fine, sorry. So these are my disclosures. So, of course, before we go to the effect of hemoadsorption, just a few, let's go back to a few basic notions and what is PK/PD, pharmacokinetics and pharmacodynamics. So of course, pharmacodynamics are the effect of the drug on the body. That's the expected effect when you administer a medication to a patient. While the pharmacokinetics are the effect of the body to the drugs, and they include 4 phases. The first one is, of course, the absorption. We're talking a lot about adsorption, not to be mentioned. Here it's the process of the drug moving from the site of administration, the mouth, the oral, the gastric tube, the intestine, through the blood, to the systemic circulation. Of course, this is very easy when it's an intravenous administration. Then there's this distribution phase where the drug is distributed to the various tissue, and then the metabolism phase, in which the drug can be processed into active or inactive metabolite, and finally the excretion phase, where the drug is removed either as a metabolite or unchanged. There are different phases that we report when we discuss pharmacokinetics. Of course, the absorption, the lag time, which is, as we mentioned, only concerning the oral administration or the non-intravenous administration of drugs, the peak concentration, then the half-life, and the area under the curve. And each medication has its own way of being evaluated for its efficacy. Some require high peak concentration, for instance, aminoglycoside, which have a killing effect proportional to the concentration, whereas other antibiotics, such as beta-lactams, are more have a killing effect proportional to the time above an MIC. So these parameters need to be understood and put in the perspective of the pharmacokinetics evaluation. Sorry, I'm going backwards. Another very important parameter when we talk about pharmacokinetics is the volume of dilution or volume of distribution. It's simply stated, it's the volume in which the drug is diluted, and if you want, it's the dilution, the ratio of the amount of drug in the body divided by it's the volume in which it is diluted. And then here you can define the 2 big types of drugs, the hydrophilic drugs, which are diluted only in the extracellular water, as opposed to the lipophilic drugs, which are diluted in the extracellular water as well as the intracellular water. So they have a much bigger dilution volume, and therefore their ability to be removed by extracorporeal therapies is much lower for same given dose. The other parameter that is of major importance is the protein binding. If a drug has a very high affinity for proteins, and albumin is the main one, its free fraction, which again is the one that is amenable to removal by blood purification or blood modification therapies, is going to be very different. The protein binding of a protein can be altered by many parameters. It can be altered by the systemic pH, the presence of heparin, hyperbilirubinemia, etc., etc. So there's many parameters that will increase or decrease the affinity of the proteins of the drug, to the proteins. And this again is very difficult to predict. You can have some models in normal patients, but in a given patient, it's difficult to really make sure what is the actual protein binding. So all that elements considered, we need to now discuss what is the effect of hemoadsorption. We know, and mostly we target the removal of pro or anti-inflammatory cytokines from the blood by using hemoadsorption. But of course, we know we remove lots of other things, the pattern-associated molecule patterns, damage-associated molecule patterns, and other inflammatory molecules. But also we can remove proteins, hormones, and drugs, which are the center of this presentation. And where I'm going to mostly focus on antibiotics, because in particular septic patients, they are, of course, the cornerstone of the medical management. So what do we know? Well, first we know a few things about extracorporeal in vitro behavior of adsorption. This study looked at a range of drugs, of antibiotics that were administered, and they compared their removal in normal chloride or human albumin solution in order, again, to evaluate the influence of the protein binding into their removal. They also aimed for a subset of the medication, meropenem and ciprofloxacin, studied them in reconstituted blood in order to get closer to physiology. So for the overall result, you see that there is a clearance, so there is a removal of all these drugs with the hemoadsorption procedure that they performed in this in vitro model. And there was a very minor difference between the data obtained with normal saline as compared to albumin. And though for the two molecules that they tested with reconstituted blood, they have data, and we're going to go back on this kind of data in other analyses. So this is the clearance over time, and you see that there is a bit of clearance in the square at the bottom for the ciprofloxacin. There's a bit of clearance by a CRT itself, but of course the clearance by hemoadsorption was higher. The key thing that I like to point on this graph is the fact that the clearance was very high at the beginning and very quickly decreased, and after 400 minutes, so it's just a bit more than 6 hours, it was very, very low, almost similar to that of renal replacement therapy. The author concluded that the older drugs were removed by the cartridge in a relevant amount. What does that really mean? I don't know. And that administration of additional doses should be considered. At this stage, I want to reflect on the fact that in vitro data are, of course, of importance, and they're very relevant. But they have lots of limitation to be implemented in clinical practice. Of course, I mentioned the importance of volume of distribution, which is not tested in vitro level because the volume distribution is 100%. There's no distribution. The protein binding, of course, you can have some albumin solution like they've done, but it's not the true conditions. I've shown that can be influenced by pH, by other factors in a human being. And so the bioavailability and the real ability of the molecule to be removed by the technique is not really assessed by in vitro data. In addition, and most importantly, it does not consider the endogenous clearance. because you can have a clearance of 1 liter per hour. If the clearance by the rest of the body is 100 liter, then it's going to have only a margin, the hemoadsorption will only have a marginal effect. Whereas if the total clearance is 1 liter, then of course the 1 liter will be a major increase. So this needs to be considered. So I think in vitro data are important when they show no removal. So if in vitro data suggests no or very low removal in vitro, then it's very unlikely that the removal will be significant in a real life patient. Whereas if it is significant, as shown in the previous paper, then it's very difficult to have a direct conclusion as to its utility, its consequences in patients for all the aforementioned reasons. So in vivo assessments are required. And so what do we know? What do we have from the literature? Well, we have a few case reports, a few case series, and they usually lack consistency and reproducibility. Altogether, if you look at them, it suggests some removal of vancomycin and aminoglycoside, probably minor removal for linezolid and meropenem, and a low removal of piperacillin. So there is some data, but essentially reliable data on the topic is crucially missing. And yeah, I've made the point as the introduction of the importance of this topic. A few years ago, we designed an experimental study in German pigs in order to respond or to partially respond to this question. We administered to the animal combinations of antibiotics and ran half of them with extracorporeal circulation, and all of them with extracorporeal circulation. Half of them had hemoadsorption for a duration of 6 hours. And we took some blood samples after 30 minutes, and we measured the blood concentration of the different medications. And this is the first results we had. And you see here, for the vast majority of the drugs we tested, we had indeed, as in vitro data, a clearance by the hemoadsorption device. However, surprisingly, we had a negative clearance, so a release of the molecule for ganciclovir, and a very low removal for metronidazole and cefepime. So there is a removal, and this is for the majority of the molecules. Sorry. Actually, what we did as well is we measured, or calculated, estimated using pharmacokinetic models, the endogenous clearance. That is what the animal is able to remove by itself. And then we put the removal by the device in perspective to the removal by the animal itself. And you see that puts the results in a very different perspective. So the white part of the bars are the endogenous clearance, and the black or gray, dark gray are the clearance by the hemoadsorber. And when you see that, then it changes a little bit the picture. You see that for the vast majority of these drugs, the clearance by the adsorption device was relatively low. It only increased by a few percent, or less than 25% or 30% the total clearance. Doesn't mean it's completely negligible, but it's not as massive as you would expect. Of course, for those that are, for some of them, it was significant. And this is particularly the antifungal drugs, amphotericin B, fluconazole, and linezolid as well. So I think we need to know what we're doing, and we need to know that not all drugs are influenced in the same way by the solvent. When you look at the kinetics and the time effects here, you see that similar to the in vitro data, there's a decrease over time, and the maximum removal occurs in the first hour. For beta-lactams, this might have this even was associated with a release after a few hours. So that is this process of desorption that has not really been described many times, which for beta-lactams might be associated with the prolonged and potentially a favorable pharmacodynamic effect. For antifungal, these are the data. You see that the removal was more sustained. And I'm just going to focus on tobramycin, where we really saw a very high removal in the first hour, followed by almost no removal in the rest. So it's really important to remember and to realize that the effect occurs really at the very beginning of the therapy. We then sought to evaluate some correlation with different parameters, but in this data we failed to really show a significant association, except for a weak correlation with the lipophilicity. So the more lipophilic the drug, the higher the removal. Of course, the data has a limitation. It might not translate to humans. Pigs are different species. They might be different to us. But most importantly, we want to give the therapy to patients with sepsis, and those were healthy animals, and this might be also limited. We might also have renal, liver failure, CRT, competitive adsorption. All these elements might limit these findings. Also, we only looked at 6 hours, and maybe there's some delayed resorption, and that might, by the way, also apply to other molecules, and we don't really talk about that so much. The drug dosage that we use might not represent clinical practice. And also, you've seen that we use that with a particular adsorbers, and this might not be similar with all kind of molecules. So here in this JAFRON symposium, of course, we would like to know a bit more about HA380. And exactly for this purpose, we have currently designed with my mentor, Rinaldo Bellomo, a similar study, this time in sheep. In sheep, we are doing hemoadsorption with HA380, and these are the details of the circuits and the way it's run. We're going to do 6 sheep and 3 sessions for each. These are the medication we're planning to study. You see, it's a bit similar to what we've done, except there are some non-antibiotics medications of ticagrelor, quetiapine, cyclosporine, rivaroxaban, escitalopram, and metformin. So this is a broader exploration of the medications, of the ability of adsorption to remove medication in such patients. Already preliminary data have been published by Rinaldo and his team, and they're very similar to what we found with the other adsorber, where we found a very steep decrease, and here the curve is a bit different. You see in the first hour the maximum removal occurs in the first 60 minutes for vancomycin and gentamicin. So also similarly considering suggesting a very high removal in the first hour or first 1.5 or 2 hours, followed by a very steep decrease in the removal. And so more data will be coming. The experiments have been conducted, and the analyses are currently the analyses are currently being performed. We also have to consider that when you do CRT in parallel, or rather hemoadsorption rather in parallel to CRT, RT itself is really going to influence the removal of the drug, and that has to be considered as well. Of course, the properties of the drug, the proportion of the drug, the renal clearance, the molecular weight, the volume of distribution, the plasma binding, and the adsorption, the adsorptive capability of the membrane itself also need to be considered. So this is all very complicated. We have recommendations. We all have booklets in our institution with recommendations which are, remember, based on healthy volunteers and models that are validated in patients who do not have AKI and who do not, like these patients with 20,000 equipments. And in these patients, there's lots of parameters that make the administration and the choice of medication extremely complicated. So I think by all means, the recommendation today is to perform the monitoring drug, to monitor the drug levels. And this is true for antibiotics, in particular in sepsis. Whatever we know we have hemoadsorption that might remove a little bit more, but this is only one of the components of an extremely complex system. By that, I would like to conclude this presentation. So I think we will all agree that renal replacement therapy and hemoadsorption greatly influence antibiotic levels, that the effect depend on the drug properties, and we are moving towards understanding better the consequences of hemoadsorption on the drugs. In a pig model, we found that the effect of hemoadsorption was relatively limited on the majority of tested drugs, including beta-lactams. However, it increased the clearance of fluconazole and linezolid, and to a lesser degree of the posaconazole, teicoplanin, and amphotericin B. Data on HA380 and is eagerly waited, and it's coming soon. Be patient. And in any case, this data needs further confirmation in human patients with septic shock. And in the meantime, and probably even after, we will have to continue using therapeutic drug monitoring for all our patients. Thank you very much.
Thank you, Professor Schneider.
Antoine, for a great talk. We're going to proceed to the